Welcome to tonight's webinar, which is all about answering your questions about migraine. First up, just some housekeeping. To get the most out of this session, we just want to make sure that you have a good internet connection. So check that you don't have any unnecessary applications open or videos playing on other devices. Next up, the Zoom reactions. So send these through. They're just in the Zoom toolbar. If you're finding something super interesting or loving something, yep, we can see some of you found them already. Thank you for sending those through. But yeah, keep the reactions coming throughout the presentation. Next up is the Q&A function, also in that toolbar. This is where you'll submit questions for the speaker in tonight's session. And tonight is all about asking questions. So please start submitting them early on. There's already one question that's been submitted. You can upvote for questions by clicking the thumbs up symbol here. And we'll prioritize the questions with the most upvotes in the Q&A. Next up, for anyone who is maybe tuning into their first session for the week tonight, or who doesn't know much about the Brain Foundation, I'll just explain a bit about what we do. So, our primary goal is to fund Australian research into brain diseases, disorders, and injuries. And we also provide informative resources about different brain disorders, raise awareness, and advocate for the patient community. Tonight's webinar is like the past 3 days for anyone who's interested in improving their brain health. However, more specifically, this will be helpful for people who are living with migraine or headache disorders, for parents, partners, and caregivers, for people who want to connect with others in the community, and most importantly for tonight, anyone who would like to ask a question. Now I'll introduce tonight's speaker, Dr. Catherine Stark. Dr. Stark is a headache specialist and general neurologist with expertise in chronic migraine. She practices in the Department of Neurology at Austin Health in Heidelberg in Victoria, and she has a private practice focusing on complex headache care. Dr. Stark has co-authored several research studies on headache disorders, and some highlights have focused on daily chronic headache, the relationship between sleep apnea and migraine, and the effects of Botox on migraine. So we're really thrilled to have one of Australia's leading headache experts here tonight to answer your questions. And tonight I will actually be taking a back seat and I'll be your moderator in the chat. And for the Q&A, I'll be handing the reins over to Carl Cincinnato, who heads up our division, Migraine and Headache Australia. Carl has lived with migraine for 30 years, so he knows exactly how much migraine can impact a person's life. He works to help lift the global burden of migraine via Migraine and Headache Australia and a number of other global coalitions and working groups. He's a member of the International Headache Society and is the founder of the Migraine World Summit. And the Migraine World Summit actually starts on the 20th of March, a week from today. So if you want to keep learning, that's a great opportunity to do so. Carl is a public and passionate advocate for migraine, and he has spoken nationally and internationally on TV, radio, and in print about migraine and the need to increase research funding, reduce stigma, and increase patient support. I'll hand things over to Carl now to introduce Migraine and Headache Australia. Thanks, Carl.
Thank you, Anik. It's lovely to be here, and thank you for that introduction. I am thrilled tonight to be able to ask questions to Dr. Stark on behalf of the community. Before we jump in, we'll talk a little bit about Migraine and Headache Australia. And if we can move the slide forward, we essentially have three functions. One is to provide trustworthy and reliable information. The second is to fund research towards a cure. And the third is to advocate and support people living with headache disease. And that's something that we've been doing now for the last 20 years for the 5 million, roughly, Australians that live with migraine or headache. And if you haven't asked a question yet, or if you are looking for questions, you're looking for inspiration, now's a good time to throw it into the Q&A. Have a look first in the Q&A section to upvote a question that you may want to see an answer to. Your question may already be there. And if it's not, then feel free to ask your question. So go ahead and do that. We're going to do a very quick overview on migraine, just covering some fundamentals on this slide, and then we'll go straight to the Q&A. And we'll try to focus on the questions that have the most upvotes, because that indicates to us that that's what the most people want to hear the response to. So quick overview. I know for most people, this is going to be revision, but it's just good to set the scene. Migraine is a recurring, complex, and often disabling disorder. It's much more than just a headache. In fact, for some types of migraine, you don't even need head pain for it to be migraine. It's very common. It affects about 1 in 7 adults. It's 3 times more common in women than in men. And it's a little known fact, but migraine is actually the second leading cause of disability worldwide, according to life adjusted years of disability. The most common symptoms, as you can see in the graphic on the right hand side, is head pain, nausea, light sensitivity. That's actually a quick way to tell without a formal diagnosis, a good indication that you may have probable migraine, but it's always good to get checked by a doctor for an official diagnosis. But migraine can be a lot more complicated than that, and it can include things like visual auras, sensory symptoms. You can have tingling and numbness in the lips and extremities, like the nose and fingers. You can experience motor weakness and many other strange and unusual and potentially scary symptoms. A lot of adults that experience a migraine attack for the first time go to the hospital thinking they're having a stroke. So let's learn a little bit more about it. I'm going to invite Dr. Stark to come on camera now, and we'll jump to our Q&As where I can see there's already a bunch of great questions coming through. So we'll kick off first with Rhonda's question, which has 7 upvotes. Is there any evidence to show that there is improvement with migraine after menopause?
Hi, Carl, and thanks, Rhonda, for your question. We know that there are a lot of relationships between female sex hormones in particular and migraine. So women who have noticed a lot of hormonal sensitivity throughout their lives are more likely to have an improvement in their migraine after menopause. So we know that through childhood, males and females are just as likely as each other to have migraine. You hit puberty and the prevalence among females skyrockets and the prevalence amongst males stays pretty even. Some of those women will notice a significant change in their migraine around the time of their period, and they may notice a significant change in their migraine through pregnancies. If these have been major factors in a woman's migraine, she's more likely to notice an improvement after menopause.
Okay. The next question from an anonymous attendee is, what are the best non-prescription medications over the counter for migraine?
So there are acute medications and preventers in the management of migraine. So non-prescription acute treatments that can be helpful for migraine would include paracetamol, aspirin, particularly orally absorbed aspirin, and non-steroidals can all be really useful options. In terms of preventatives and non-prescription options that have got an evidence base behind them include magnesium, vitamin B2, coenzyme Q10 to some extent, and butterbur. There are some cocktails of supplements available that package it all up together. So if you have a chat to your pharmacist about them, making sure it's something that contains magnesium and vitamin B2 is worthwhile. It's also important to not exceed the recommended doses of these supplements because if some is good, more is not necessarily better.
And just going a little bit deeper on this question, the idea of being able to take medication that's non-prescription for migraine to manage it really is appealing because it saves us having to get a prescription, go to the doctor, all that sort of stuff. But it feels like it can also be, well, it I think it can also be dangerous to do that too, because there are treatments for acute migraine and for prevention of migraine that have demonstrated to be much more effective, particularly if you have frequent or disabling attacks that aren't quite managed or controlled by over-the-counter medications. There are people in the population who perhaps can get that control, but what would you say for those people who are having, still disabling attacks despite being on those medications?
And seeking help is a really important thing to do. So I know there are definitely roadblocks to seeking healthcare in Australia at the moment. People are struggling to get in to see their GPs and everyone's time poor. But just because you've always had migraines and they're normal for you doesn't mean that it's normal for you to put up with them going forward. So I would definitely encourage you to seek medical attention if you're not getting enough relief from those over-the-counter medications.
Do you have like an idea of what should be the goal of an acute treatment and a preventive treatment for people with migraine?
So an acute treatment should get rid of your attack, is the ideal situation. So it should be something that you can take and your pain goes away and a lot of those non-pain symptoms settle down and you're able to get on with your day. That's not always achievable, but that should always be the goal of finding an acute treatment that does that for you. Preventers, in an ideal world, they would get rid of your migraine completely, but that's not going to happen for the majority of people. So I would say if they reduce your migraine frequency such that they're no longer having a significant impact on your life, that would be considered a positive outcome from a preventer.
And what about if they reduce the frequency or severity of your attacks by half? Like, would that be a good outcome?
Yeah, so half is great. It depends a little bit where you're starting from. So if you're getting 30 migraine days a month and you get down to 15, that's going to be absolutely brilliant. But we would prefer to see people even lower than that because 15 migraine days a month is still a lot. So the ultimate goal is to try and minimize the impact of migraine on an individual patient's life.
Okay, thank you. Michelle has a couple of popular questions here. So Michelle, we're going to answer a few of these now. The first being, do people with migraine have an increased risk of stroke?
Yes, they do. So having migraine with aura will roughly double your baseline risk of stroke. So mostly people who experience migraine tend to be younger people. So your baseline risk is low. But if you do have migraine with aura, it does increase that. If you add on top of that an estrogen-containing hormonal preparation, contraceptive, that risk increases to about 8 times your baseline. If you add smoking on top of migraine with aura and an estrogen-containing contraceptive, that bumps it up to about 20 times. So I would very much urge anyone who does have migraine with aura to avoid smoking at all costs and to think hard about the necessity of being on an estrogen-containing hormonal preparation.
Yes, that's me. I've got migraine with aura. Fortunately, I don't smoke. I saw from the statistics, it was something like 2 out of 10,000 people. Like that's the kind of risk of a stroke. And if you have migraine with aura, it goes to like 4. So even though it sounds really scary, like you're doubling your risk, the actual numbers are still quite low by I guess statistical comparisons. So it's not anything that people should necessarily, if they just have aura as a risk factor and not smoking and not the contraceptive pill, it's not necessarily something they should be worried about. Is that right?
That's right, unless you've got a higher personal baseline risk of stroke. So if you've got high blood pressure, high cholesterol, a strong family history of stroke, then I would certainly urge you to get all of those modifiable risk factors as well controlled as possible. But having migraine with aura is not a modifiable risk factor. You've got it or you don't. So there's nothing you can do about your brain, but those other risk factors definitely can be managed.
Right. Is there a relationship between neck pain and migraine?
Yes, there is. It's a very interesting story, the neck pain story. So it seems to be two directional. So we know that neck pain can be part of any part of a migraine episode. So I'm sure a very well-informed community knows that a migraine is essentially in 4 parts. There is a prodrome that can be 6 to 12 hours prior to a migraine. There's the aura phase, which not everyone has. There's the actual headache phase, and then there's the postdrome. And neck pain can be seen in any of those parts of the migraine. Often if people get neck pain as part of the prodrome, they can attribute the migraine as having been caused by the neck pain. So people will sometimes think that they're getting a cervicogenic headache. So their headaches are caused by having a stiff sore neck. Whereas in actual fact, the neck pain is the migraine starting. And we wonder if some of the reports we get of people going to get a massage and the massage really setting a migraine off to potentially be neck pain started migraine, they get a massage, get a migraine that was coming anyway. That said, if you do have a neck problem, so a neck that is sore in between migraine episodes, we know that all of the pain wiring of your head and neck passes through the same trigeminal vascular neurons in your brainstem. So any pain input to that area, be it a toothache, neck pain, head pain from some other cause, bruxism, that's all going to lower your threshold of being tripped into a migraine attack.
Yeah. I actually personally had a shoulder injury that damaged nerves in the shoulder and led up to the back of my neck. And the neck was such a confounding factor in my condition that I never properly rehabilitated that injury. And that's what sort of spiraled me down into chronic migraine. I've heard from patients that the migraine can actually start and finish in the neck and not actually have like typical head pain around around the temples or, behind the eyes. Like that's so common in migraine. Is that possible? Have you seen that?
Yeah, absolutely. And it's really confusing for patients when that does happen. A good tip for that is if you've got triptans that work on your neck pain, that's a migraine. So
Yeah.
they're not going to do anything for musculoskeletal neck pain, but they will impact on migraine. So if triptans fix your neck pain up and your neck pain's only there around the time of other migraine symptoms, migraine is usually the chicken rather than the egg.
Yeah. Fantastic. And another question from Michelle is, do you think migraine is triggered more by hormones or genetics?
So the genetics are, I guess you wouldn't think of them as a trigger. We know that you're very much more likely to have migraine if you have a family member with migraine, and there's a huge number of genes that have been found to be associated with a predisposition to migraine. So I think of migraine as a genetic condition, not one that's really cleanly recognized in terms of the way it's passed on. But that is your default brain setting, is your genetic background. And then the hormonal fluctuations through a woman's life in particular are more of a trigger for an acute episode. So the genetics set you up for the migraines, but then the hormones can trip you into an episode.
Yeah, makes sense. Chris had a question. Is there a point in the development of a migraine when one can stave off the severity of the attack?
As early as possible is the short story. So most of our migraine acute treatments work best when taken at the very start of the pain phase. I tell people to take them during the aura phase if they do get an aura. That's less clearly demonstrated to be effective. And we don't know that taking them even earlier during the prodrome works better. In the absence of evidence, I think that if you've got a sufficiently recognizable prodrome that you know a migraine is definitely coming, I advise people to take their acute treatments even during that phase, but we don't really have the hard data to back that up as an appropriate approach. But yeah, the sooner you can stop that cascade of neuropeptides from triggering off, the better you're going to do within the attack.
And would that also be the case for people that have migraine with aura, if they're getting the aura phase?
Yeah, yep. So as soon as that aura starts, I just find your drugs and take them as soon as you can.
Great. And one of the things that I think I've found quite helpful is that sometimes, the drugs you have are quite precious. You can only take a certain amount of triptans each month. You can only take a certain amount of those other medications. Even the over-counter medications, you have a limit on how often you can take them because you don't want to have medication overuse headache or rebound headaches. But are there things that you can take at the first signs that you can almost use without restriction to just put you at ease so you don't have this anxiety and this catastrophization that can even self-fulfill the migraine attack, because of the fear and worry?
So there are no medications that I would say absolutely go gung-ho at. So take them whenever you want to. I'm pretty relaxed about paracetamol and non-steroidals. Aspirin, you just need to be a little bit careful because I find that high dose aspirin works best and you don't want to be taking high dose aspirin all the time.
Mm.
But those non-medication options are a great option for the very early stages, people who have got really frequent migraines. So things like ice or coffee or heat packs, whatever works for you from a non-prescription medication point of view, can be used whenever you like. Some of the neurostimulator devices as well are great to use as often as you can. The one exception from the medication point of view is the GPANs. So we know that the more you take them, the better they work. But sadly, they are a very expensive option in Australia at the moment. So while it would be good for your health to take them more frequently, it's not going to be great for your pocket.
Yeah. So one example of that is Nurtec ODT, the orally dissolving tablet that's available in Australia, but it's not on the PBS. What about ginger? Has ginger got any evidence to support its use?
Not that I've come across. So, but take it as often as you like. We know that it can be helpful for nausea in particular, but I'm not aware of any specific migraine lytic evidence for ginger.
And what about anti-nausea medications? My understanding is that they don't cause rebound headaches and that they can have a pain relieving effect. And especially if you have nausea during a migraine attack, which is one of the most common diagnostic criteria, if we take that medication, that could potentially help stave off an attack.
So in terms of the anti-nausea medications, ondansetron is the one that works best for the nausea side of things, but it does not have a migraine lytic effect. So stematol is the one that probably works best as an anti-migraine drug. It will not cause medication overuse headache, but there are other risks for using stematol every day. It can contribute to movement disorders down the line. So it's not something that you want to be using really frequently. But if nausea is a prominent component for you, if disequilibrium or dizziness is a strong component for you, then that is a good option as well.
Okay. And so really when you're getting to the point where you're having, 10, 15 days of migraine, like prevention's kind of the name of the game. Like
100%. If you feel like you're needing to reach for acute medications so frequently that you're worried about the impact they're having on your health, you need to be on an effective preventer.
what would be that threshold? How many days of migraine headache or how many days of migraine symptoms would you say you should start thinking about that? Start thinking about prevention?
Again, it's individualized. So for some people, one bad migraine day a month is enough to really significantly impact on their life, their career, the way that they're living. Other people, if you have the capacity to go to bed and rest, it's not such a disaster. But my general threshold is about 3 episodes in a month, or an episode that's bad enough to stop you doing what you want to be doing.
Right. We had a question here about how do you know if your headache is migraine?
As in from a diagnostic point of view, or in someone who gets headache and migraine? We can talk about both.
Yeah, let's do both.
So migraine, as opposed to headache generally, you identify in that it is more severe than your average headache. So it's of at least moderate severity. It's more likely to be one-sided. It's more likely to be throbbing rather than tight, but that's far from a hard and fast rule. It's also more likely to be associated with nausea, light and sound sensitivity, and other sensitivities, and it'll get worse with exercise. It's interesting when you talk to people who present with headache for the first time and talk about some of those features of a headache that define it as migraine. They look at you like you're an idiot. Like, of course my headache gets worse when I'm around loud noise. And of course it gets worse when I exercise. Because it's been normal for people to experience headaches like that their whole life, and that label of migraine has never been stuck on it. But if any of those features are present, it's really likely that you are suffering from migraines. Likewise, in an individual who has both headaches and migraines, if any of those features are present, it's more likely to be a migraine headache rather than a background or tension type headache.
Tim said that migraine is listed as a mitochondria disease symptom. What's the connection, he asked?
So there are some mitochondrial diseases that are associated with migraine-like headaches. These are a very small minority of people who get migraines, and they're usually very severe, very frequent, and can have quite an explosive onset. So if you have had terrible migraines appearing for the first time and they're really significantly impacting you, particularly if you have other health concerns, such as diabetes or visual problems or short stature, if there's a strong family history of migraine, it would be worthwhile having a chat to your neurologist. And most of those disorders can be identified on an MRI scan.
Great. Can you tell us what are eye migraines?
So migraines, sorry, that was eye migraines.
Yeah, this question came through from Caroline.
Yeah,
Carolyn, sorry.
so part of migraine without aura can be some non-specific visual disturbance. You can get some blurring, some difficulty focusing, some difficulty with depth perception. Migraine aura can have more specific visual disturbances, often positive visual disturbances, where you might get extra spots of light in your vision, excuse me, zigzag lines, kaleidoscopic visions, typically that evolve over a period of 10 to 20 minutes. And typically, if people are referring to eye migraines, they might be talking about a visual aura preceding a migraine headache, or they might be talking about visual aura in isolation without headache. So typically people would be talking about those evolving positive visual changes.
So it's not an official migraine subtype.
No. So retinal migraines are really a type of migraine where you get a lot of visual aura, and that can happen by itself, but it's usually part of a broader migraine spectrum.
Great. Just before we jump to the next question from Michelle again, we've got very popular questions. Thank you for the great questions, Michelle. We're going to do a quick poll. Would love to hear from you whether you have attended the Migraine and Headache Awareness Week last year. So that poll will come up. You'll get a notice about it. Right, there you go. It's just popped up. As you answer that poll, we'll ask another question from Michelle. Are there food triggers for migraine?
Probably less so than we used to think. It's infrequent that I'll come across a patient who has a really good going clear-cut food trigger, but it does happen. So ones that people can report are oranges, chocolate. Probably the most common would be alcohol, so wines in particular. But we're increasingly, with a lot of the triggers for migraine, we're starting to think of it as perhaps more of a prodrome, rather than a trigger. So people thought that chocolate and sugar were a really strong trigger for migraine in the past, but we now know that the prodrome of migraine can include carbohydrate craving. So similar to the neck pain, perhaps people are developing a migraine, they get that carbohydrate craving, they eat the chocolate, they eat the sugar, they then develop the migraine and blame the sugar or the chocolate, whereas it was actually part of the migraine process that led them to eat that in the first place. That said, I do think that there are some individuals who will find that some foods set them off. I have one patient where capsicum will absolutely set her off, even if it's smuggled into food. But I think it's not as common as we used to think. I also see patients really go down a rabbit hole of keeping extensive food diaries and trying to do these crazy exclusion diets that take up a lot of their mental bandwidth, and I've not seen really positive outcomes from changes in diet. The one dietary factor that is definitely a trigger for migraine is prolonged fasting. So skipping meals is bad news. And people can sometimes notice a real explosion in their migraine if they have changed their diet for fasting, for weight loss, or for other health purposes.
Yeah. I think that's fantastic insight. For me, like if I have a glass or just a sip of champagne, it's an instant headache. Not necessarily a migraine, but instant headache. And then if I keep going, then it'll almost certainly develop into a migraine. Even though, today I'm low frequency episodic and far more resilient for just whatever reason, champagne will set me off right then and there. And I had a recent migraine attack and it was triggered by ice cream. And I had ice cream again when I was feeling good, and I almost had another attack, but I would manage to kind of, intervene. And yeah, it's just one of those things. When it comes to the diet, a lot of people have asked us at Migraine Headache Australia, what's the best diet for migraine? How do you respond to that?
I respond with a varied, healthy diet. So basically, not skipping meals, avoiding major exclusions. I've had a couple of patients who have tried the ketogenic diet, which there's mixed data about that potentially being helpful. I've had a good few patients who have had a disastrous time with their migraines trying that. So there'll probably be different genetic subtypes that are going to respond to it differently. But I advise people to just keep their diet varied, keep it healthy, avoid processed foods to a not ridiculous extent, and so similar to the advice you'd give someone who's got hypertension or heart disease.
Yeah. I mean, it just like the common thread amongst so much of the diet advice is the less processed food you eat, the better. But at the same time, you're human and life is for living. So, it's up to you to draw that line as to how strict you can be. And, if you're going to let yourself go at the wedding or at the party, just that's great. But, take a little pill jar with you just in case you need it, right? Like, just plan ahead. What
Absolutely.
about omega-3s? There's been some research lately that's come out to talk about omega-3s potentially being protective or helpful in migraine prevention. Have you seen anything about that?
I must say I'm not all over the omega-3 studies. So I know that they're generally good from a heart disease, hypertension point of view. And I think the general idea is that they're an anti-inflammatory options, and anything that is anti-inflammatory is going to be helpful from a migraine point of view. But I can't say I've seen those studies specifically.
Okay. Rebecca had a question about Botox, and she wanted to understand whether if continuing Botox would maintain its efficacy, the continuing efficacy of Botox treatment.
Yes, so we know that Botox will continue to work better for people for at least the first 2 years of treatment. That's about when our data stops. So we see better and longer lasting responses over those first 2 years. From my personal experience, people who have responded to Botox will typically continue to respond to Botox, particularly those really clear-cut responders. There is a significant placebo effect to Botox. So anything that involves a needle in particular will tend to have a really powerful placebo effect. And we did see that in the original trials. And sometimes you will see people have a great response to the first round or two of Botox, and then the effects waning after that. I think that probably is the placebo effect wearing off as opposed to a change in the actual Botox effect with time. People will talk a lot about antibodies in Botox, but it's unbelievably rare to develop antibodies to Botox. I've seen, I don't know, thousands of people with Botox over the years, and I've seen one person who's developed Botox antibodies where it worked, and then suddenly stopped working absolutely. So generally, if it works for you, it's likely to keep working for you.
And how long does it take to find out whether it's going to work for you? So if it doesn't work in the first 2 weeks or 3 months or 6 months, how long should we keep going for it?
So in Australia, we call it at 6 months to see whether it's worked or not. There is some data to suggest that 9 months would be better. So you do still get a few people responding to a third lot of injections who didn't respond to the first two. So I would always encourage people to have at least 2 cycles of Botox to see if it works for them before they reject it. Likewise, if you have a side effect from the first lot of Botox, some neck weakness or some cosmetic difficulties, have a chat to your neurologist about that. They can tweak that the next time, and don't make that a reason that you stop prematurely before potentially seeing the benefit.
Stacey had a question about TBIs. In what ways do TBIs cause migraine, and can such migraines, or she's put here BPPV, which I think is benign paroxysmal positional vertigo, increase later in life?
So we're talking traumatic brain injuries, just to clarify.
Yeah.
So trauma can definitely be a trigger for migraine. So it's unlikely to cause migraine in someone who's got absolutely no genetic predisposition for it. But it's quite common for people to go from the occasional nasty migraine really not impacting on their life to migraine becoming absolutely devastating after a head injury. So it's actually considered a separate subtype, so a post-traumatic migraine or post-traumatic headache. But increasingly, we are treating it the same as we would treat other forms of chronic migraine in particular, particularly the headache that has a lot of those migraine features going along with it. So it is a known trigger for chronification of migraine and for increasing migraine severity. And we need to try and get on top of headaches as soon as possible after an escalation event like that.
And with the BPPV, that's kind of a vestibular balance type issue and symptoms. Um, I've seen a lot of patients talk about that becoming a really bothersome symptom later in life, in particular, as the head pain tends to wind down, these other symptoms come to the fore. Do you see that in your practice as well?
Yeah, so BPPV specifically is quite separate from migraine. So it's a disorder of the crystals in your ear coming loose, setting up strange currents and making you feel dizzy and ghastly. So I think what we're talking about there is vertigo in the context of migraine and how that can impact things. So absolutely, you can see disequilibrium and vertigo becoming more prominent for patients as time goes by. Often sort of around patients in their sort of late 40s and 50s will notice a change in the pattern of their migraine from short, sharp, classic dark room, vomit, and then I'm fine for the rest of the month, to typically milder headache that goes on and more of those non-pain symptoms becoming more prominent. So dizziness can be a huge source of disability in patients with migraine. It can be an aura, so it can be 20 minutes of severe vertigo at the start of a migraine, or it can be a persistent seasick, imbalanced feeling throughout the course of the migraine itself. And you can actually have episodes of vestibular migraine where there's very little pain or none at all and just dizziness and nausea.
Yeah, good to know. We had a question about magnesium. That was mentioned earlier. Is there a particular type that you prefer or that you think is more effective with your patients?
No, I find that patients will typically tell me what they like, and it's very varied what they come up with. So it's typically a really well-tolerated medication, but some people can find that they get a bit of diarrhea with it with some preparations. Maybe magnesium glycinate is a little bit more favored by patients, but I would just have a play around if you're getting any side effects and find one that suits you more than others. But you want to take a decent dose, so at least 600 to 800 milligrams.
Okay. And then is that usually twice a day, sort of 300 in the morning, 300 at night if you're doing
So
600?
so they're often 500 milligram tablets. So I would tell people to take two of them. So yeah, one in the morning, one at night works well.
Okay. Yeah. I mean, that's what I take. I used to take a whole bunch of supplements and vitamins. I used to rattle when I walked. And as I was getting better, I was like, okay, I'm spending a fortune. I don't know which of these is working, but I don't want to, relapse. So gradually, one by one, I took away the supplements, and the only thing I really noticed the difference was for me at least was magnesium, and I still take it every day now. And it's magnesium glycinate that I use too. So
Yeah,
hope that helps.
add you to my glycinate fans column.
Yeah, yeah. Well, there's magnesium that's it's I think it's pronounced like chelate, which means it's more sort of it's less sort of harsh on the gut, that it's less likely to cause those symptoms, which I've found that's worked quite well for me. So yeah, you can put me down for a fan of glycinate, magnesium glycinate. The next question we have is from Nicole, and she asked if factors like stress and anxiety and insufficient sleep are linked to migraine.
Yes, absolutely. So stress is important in two ways. So it's important in terms of your risk of chronification of migraine, so worsening in your baseline migraine. We know stress in early life. We know that stress right now and sort of global life burden of stress are all risk factors for migraine worsening, so migraine chronification. On top of that, stress today is likely to trigger a migraine attack for you. Some people will find that in the course of the stress, they'll have a migraine triggered. And you can also see post-stress. So the classic is a VCE student who gets through their exams, gets onto holiday, and then falls in a hole the next day with shocking migraines. So that can also be seen, people who get a Saturday morning migraine, they sort of make it through the week and survive that, and then the wheels fall off on the weekend. So 100% stress can be a trigger. Difficult to avoid stress. Everyone would love to for a lot of reasons, but do with it what you will. The less stress you can have, the better. And stress management techniques can be useful in terms of reducing your risk of migraine chronification and for the management of migraine in the short term. Sorry, what was the second part of that question?
Anxiety and sleep.
Sleep. Yeah. So sleep is definitely a trigger as well. So more commonly, lack of sleep will be a trigger for people, but also you can see oversleeping being a trigger for people as well. So I would always advise people to try and get roughly the same amount of sleep every night. Having 4 or 5 hours during the week and then having a big catch up on the weekend is a risk factor for having those relief of stress migraines as well. So trying to keep it all even through the week as much as you can is your best bet.
Yeah. I can really attest to that. Sleep for me is my number one factor. If I am well rested, if I've had a couple of good nights sleep in a row, I can I can almost have that glass of champagne and every other insult I could throw at migraine. But if I've had a bad night's sleep or several bad nights sleeps, I'm so fragile and I'm walking on eggshells until I can sort of recover. And it's interesting because sleep is one of those things that most people need to do to recover fully from a migraine. So it's part of the cure, but it's also part of the lack of it is also part of the problem. So it suggests that there is this intimate connection between sleep, brain health, and migraine. And a lot of people with migraine have undiagnosed sleep disorders. Is that right?
Yeah, look, it is more frequent that patients with migraine will have sleep disorders. The relationship between sleep apnea in particular and migraine is a little bit more complicated. So you are more likely to have migraine with sleep apnea, but the more common headache type is a morning headache that we think is probably more to do with the hypoxia overnight with sleep apnea.
Mm.
On top of that, it's really common in the migraine prodrome to have sleep disturbance. So whether that is poor sleep or feeling increasingly sleepy, lots of yawning, that can be one of the hints to people that they've got a migraine on the way. And again, that bad night's sleep that's being blamed for the migraine can sometimes be because the migraine was coming.
And just to recap on the stress side of things, it's not necessarily the absolute levels of stress that we experience that's the problem. It's the changing of stress. So a dramatic increase or decrease in the examples that you were sharing, like the student or the teacher who doesn't work on the weekends, relaxing and then having an attack or a dramatic increase.
Yeah, so look, those big bursts of stress are more likely to be a trigger for a migraine, but it's the load of stress over your lifetime that's more of a risk factor for the quantification. So sort of the climate and weather type analogy, if you've got a stress climate, you're more likely to have more frequent migraines. But if you have a stress event, a weather event, then you're more likely to have an episode of your migraine.
Yeah. And it's so subjective though. I think that you can have the same event and it can be seen as something that's terribly traumatic and stressful for one individual, and for the other it's fine. And an example of that might be sort of first responders that see some pretty, intense things, and that are rightfully, quite sort of stressful. But depending on either the disposition, the resilience, the stress management techniques of that individual determines how they interpret that, life event or that encounter.
Yeah, absolutely. Our responses to stress are incredibly different, individual to individual, and just as our responses to pain are really different between individuals. So, learning what your stress triggers are and the best ways to manage stress for you is a really helpful way to get your migraine controlled as well as your stress controlled.
Yeah. For me, my secret, happy to share it with everyone here, regular exercise and meditation. I don't meditate as often as I would like these days with two young kids, but when I do, I notice a really significant difference. Everything's better. We have a question now from I'm gonna mispronounce the name. I apologize, but Shinna, and she says that she has migraine and has tried several treatments. Nothing's worked until she was put on propranolol, and that made a big difference. How is a beta blocker helping migraine?
Yeah, so the answer for most of our tried and true oral preventers are we don't know. So all of these drugs were designed for something else first and were found incidentally to treat migraine and have been used for many years. A lot of them, we have very little research to back up the fact that they actually do work, but we know from many years of clinical practice that they do. For beta blockers in particular, we postulate that part of the way that they work is they essentially block your fight or flight mechanism to a certain extent, and they can impact some of those physical manifestations that can come along with anxiety. So they can reduce your heart rate, reduce your tremor a little bit. So everything sort of slows down and settles. But there are other blood pressure lowering medications such as candesartan that do none of those things and also work on migraines. So the mechanisms are obscure to us, and I doubt that we are ever going to get really good studies on them because they are old, cheap drugs that no one's going to pour lots of money into studying.
But they're great to trial, right? Because they are cheap and it's easy to sort of, use to give to patients, see if they respond. If not, okay, move it on and continue that sort of escalating trial and error process to find something that does work.
Yeah, and look, a lot of patients will start to feel really disheartened when they've tried 1, 2, 3 medications and it's just not working for them. And a lot of them will throw in the towel at that point and just say, oh, well, I've got untreatable migraines. I'll just have to live with it. I would encourage you not to do that because while we are not fantastic yet at picking what is going to be the best oral medication for an individual, there may be one that works really well for you and the other ones don't. So keep at it, keep trying, and don't despair because usually we are able to help people with one medication or another.
And I think it's helpful to know that it is a process of trial and error because there is not one treatment that works for everyone. There's going to be like a prioritized list based on your personal medical history and your health profile. And we're going to work through that list, systematically and, get to an outcome that, works for both of you, the doctor and the patient.
Yes.
Rhonda had a question. She's probably seen me drinking from my cup. Does water consumption affect migraine?
So don't let yourself get dehydrated, but drinking 12 litres of water a day is not going to help. So not too little is the most important thing. So most patients with migraine would know that if they spend a day out in the sun don't drink enough, exercise a lot, they're likely to get a migraine by the end of that day. So you absolutely want to avoid dehydration, but there is no evidence that drinking lots and lots of water is going to make a big difference.
And if you have lots and lots and lots of water, it can affect your like electrolyte balance, right? So you may need to counterbalance that with some electrolytes.
Yeah, absolutely. So if you drink more water than is good for you, it can dilute the salts in your blood, which can make you really unwell. So don't overdo it.
Good to know. Rosemary was listening to our conversation about food triggers earlier, and she said if there's so many different food triggers that can be potentially a trigger for different people, what is the biological mechanism in the brain or in the nervous system that's causing that? What's actually happening in the brain, body, the head when it hurts?
I would love to be able to answer that for you, Rosemary. We don't know why some foods trigger migraine. We presume that it's something is setting off this cascade of neuropeptides that will set each other off and cause that migraine process to start. But what flips that switch right at the beginning about some foods, we don't know.
The way that I kind of think about it, and tell me if this is like the wrong mental model, is that where as someone with migraine, the brain is malfunctioning. My brain is malfunctioning, and it is misinterpreting what is otherwise normal stimuli. It could be the food and or another trigger for something that's threatening or noxious, and I overreact. I have a hypersensitivity to it. Is that a fair way to kind of think about it?
Well, we know that sensitivities are definitely a major part of the migraine itself. So during the migraine process, people will definitely experience lights to be brighter, sounds to be louder, smells to be stronger, and even touch to be noxious where it normally wouldn't be. You hear people say even they can't wear their hair in a ponytail, or a bra strap will drive them mad when they've got a migraine there. But on top of those sensitivities, when the migraine is present, there are definitely some patients who feel that they can have a migraine triggered by a sensory stimulus. So exposure to very bright lights or to certain smells in particular, some perfumes that will reliably set people off. And I think of it as everyone having their own personal migraine threshold. If you're set up with a brain that's predisposed towards migraine, your threshold is closer to being tripped into a migraine. And then those sensory sensitivities can just be that last little thing that shoves you over the edge of that cliff and sets the migraine off. So the goals of our preventative treatments are really to just try and shift that migraine threshold down. There's nothing that's going to make you impervious to migraine and never get one, but just being able to weather those little fluctuations from triggers in day-to-day life a little bit better, and being on less of a hair trigger is a goal of therapy.
Yeah. I mean, I've found with my own threshold that it can vary day to day. It can vary when I've had a good night's sleep and or a bad one. And I kind of have to and keeping a diary has been really helpful with that to sort of to like learn and sort of know my own migraine condition, learn my own body, and to be able to dynamically adjust when I need to and course correct. But I think that's a good way to think about it, like your threshold, building your resilience, and these treatments and prevention strategies, which don't necessarily need to be medical, they can be behavioral and lifestyle, could all influence that. Is migraine does migraine occur worldwide, and is it more prevalent in our Western lifestyle?
Yes, it is worldwide, and it's pretty even across the world, actually. So it gets more reported in first world countries, but I think that's largely because of access to healthcare. But when population studies have been done, it's pretty consistent around the world. So chronic migraine sits at about 2% or so, and migraine itself around the 15% mark in most countries.
Yeah. I had a really interesting chat with a Nigerian pharmacist who was talking about wanting to do some migraine advocacy in his country, And it was something that was just not prioritized because it wasn't a communicable disease, which is what they focus on there. It's like infectious diseases, the priorities in these lower third world countries with lower socioeconomic, backgrounds, which I thought was really interesting. So you're right. I think it's just not measured in these
Well, that's the
areas.
thing. No, you're not going to die of your migraine, but geez, it's going to make life miserable. So it's uh, would be considered a luxury in some countries where the health dollar's got to go further to treat something that's not going to kill you.
So I've got the poll results to share. About 80% of people did not attend Migraine Headache Awareness Week. You will have a chance this September to attend Migraine and Headache Awareness Week, where we'll have a whole week of experts talking about migraine and headache. I know it's a little way off, but put that in your diary. And I'm conscious of the time, so I know we've got a bunch more questions. I apologize. We've been trying to answer as many as we can. We'll ask maybe one or two more, and then we'll wrap up for tonight. But thank you so much for your attention, everyone. This question from Michelle is there any evidence to suggest that taking antihistamines regularly can help prevent migraine?
Yes, there is. So a couple of our migraine preventers work on the histamine system. So periactin has got an evidence base in migraine. And Sandamigraine, one of our oldest anti-migraine drugs, has an impact on the histamine system as well. In terms of your over-the-counter antihistamines, we don't have any evidence that they will reduce your migraine frequency. But as we were talking about earlier, anything upsetting your head and neck being a potential trigger for your migraines, hay fever season can be ghastly for people who have migraines. So if you're getting a lot of congestion, a lot of pain from your sinuses or nose, that can definitely set people's migraine off. So controlling any other symptoms in your head and neck is going to be a win for your migraine as well.
All right. Last question here. I know a lot of people in the audience are women, and a lot of women have hormone as a factor or a trigger for migraine. Seeing as hormone is a trigger for so many women, can hormones be part of the solution? Can taking hormones or um, addressing hormones in some way help prevent migraine?
Definitely worth having a chat to your neurologist about if you have really strong hormonal connection to your migraine. Sometimes avoiding menstruation can be a really useful tactic for people. So that big dip in your estrogen at a couple of days before your menstrual cycle starting can be a trigger for people. So if you can even out your hormones, that can be really helpful for some patients. Others can find it goes absolutely haywire. So it's really one that's got to be individualized and taking into account any other gynecological symptoms that you're getting from your cycle as well.
Fantastic. Well, thank you so much, Dr. Stark, for joining us at Brain Awareness Week this week. I've had a great time asking questions on behalf of the audience. Thank you to the audience for your wonderful questions. Please contact us if you've still got a burning question. You can email us from the website. And thank you for attending Brain Awareness Week. We hope you found some great information and some great resources, and we will be in touch again soon.
Great. Thanks, Carl.
Bye-bye for now.